Hi, thanks for joining me today. I'm sure you've heard plenty of presentations about ADHD, and in this particular talk, I'd like to focus on adults and women, and I'm hoping that that adds an extra dimension to your understanding of the diagnosis. I'm Dr. Vanita Menon. I'm a school and clinical psychologist with a practice in the suburbs of Chicago. I've been in the field for over 20 years, and I'm really looking forward to sharing some of my information and content with you. So the credit for this term lost generation goes to one of my clients. She had the experience of going to an evaluation for her son and sitting in the doctor's office and realizing that a lot of what he was talking about described her as a child. And in advocating for her son, she realized that she also needed some support for some very similar experiences. And while she was around age 40 at that time, she came to the conclusion that there were some characteristics that were similar in childhood that really started to change and evolve as she went through adolescence and then into adulthood. And we talked about the term lost generation because there are many people in that same boat who had either didn't have access to resources or evaluation options or care, either through lack of knowledge or lack of resource, and they want to take things into their own hands, as adults. And I'm really glad to support that process. Our goals for today are to make sure that we're on the same page and with a good understanding of the background of ADHD in general. And then we want to focus specifically on adults and women. We're going to talk a little bit about measures and evaluation processes, and whether you do the evaluation or not, I think it's important information to have. So when you pick up an evaluation report, you know what to look for in a good one. And finally, I want to talk over some case examples that I've kind of brought together from different cases that I've worked on, certain clients that kind of stand out for me, and talk through some treatment plans and goals for them. So first of all, what is ADHD? What are we talking about? Well, that kind of depends on the context. This is what I mean. These are the traditional categories or subtypes of ADHD, and there are three that are identified. And these are some of the general experiences or behaviors that you'll hear people talk about. You'll have comments like, oh, I feel like my brain or my body is always on the go. I'm very busy. I tend to interrupt people even though I don't really mean to. And a lot of clients talk about a lack of focus, being forgetful, being late, having good intentions, but it doesn't show in their actions. So the three types are predominantly inattentive, predominantly hyperactive impulsive, and of course the third one will be the combined type. You'll find all of this listed in the DSM-5 TR, which is our current handbook from the American Psychiatric Association. When we look at ADHD by the book, you'll notice some key changes from the most recent version to the current one. So there's a newer emphasis on neurodevelopmental criteria, and that's important because it's really acknowledging that ADHD may begin in childhood, but it can last for the lifetime and can change across the lifespan. And there are some new examples that have been provided in the manual to highlight that. It continues to emphasize that, having these characteristics or symptoms, they are required to be present in multiple settings. They can be in the clinic with you as a clinician, in an office or work setting, at home, socially, It depends on, of course, that person's particular life experiences, but you do need to see the criteria present in more than one setting. One really important thing that's changed is the onset of when we expect to see certain behaviors. So this really helps adults in particular because they may not be the best reporters of what happened with them before age 7. So, they may be able to report better about their middle school experiences or late childhood experiences. So with that criteria changing from age 7 to age 12, it really helps the adults who might be seeking a diagnosis have access to that. Another nuance that's changed in the DSM-5-TR is that a comorbid diagnosis is allowed with autism spectrum disorder. So in the past, there may have been a distinction between the two, and now, while there are specific core criteria for each of them, it is also allowed to have a shared or dual diagnosis between these two diagnoses. And finally, for another big change is for an adult to get this diagnosis. The client or patient only needs to meet 5 symptoms instead of more in comparison to younger children. So that's an important difference too, because some of them might be sub-threshold, and I'll talk about that in a little more detail in just a minute. It also depends on how a client presents in the clinic. So what is ADHD in a clinical presentation? You might see some different qualities when you're doing therapy with a client and you're wondering, like, is there something else going on? Do they have ADHD? You might notice some heightened emotional sensitivity, sensitivity to rejection. You might notice some gender differences that come into play across genders. You might notice certain qualities of personality and motivation. Some people are highly motivated but still can't get to the outcomes that they really want to achieve. They'll verbalize that motivation but not be able to act on it. It looks different in teens and adults, specifically when it comes to social anxiety. You really might hear comments about having distress eating alone at a restaurant, feeling like the spotlight is on them even when it shouldn't be. When a bride is walking down the aisle, we expect all eyes on her and, feeling like there's a spotlight on her. But it shouldn't feel like that when you walk into a restaurant or walk in late for class or walk into a grocery store. There's no spotlight on you at that point, but for many clients, it can feel like that. Another important thing to consider is, whether how ADHD medications interact with other medications for mood. And that's why the diagnostic process is so important. It's really important to treat the front burner issues first to see what remains. If you're treating ADHD medically, it might soften some of the social anxiousness and irritability that a client experiences. There may be some residual effects that need to be addressed, and that's why it's really important to have a good psychiatric partner or a nurse practitioner to be part of the team. And that's, of course, only for clients who are seeking medication options. And finally, we do see more social anxiety, quite a bit more of social anxiety in people who already have the diagnosis of ADHD. So that tends to co-occur more often than by itself. And another area that I'd like to highlight is in the clinic, if you're seeing middle-aged or older adults, maybe 45 or 50 plus, you will hear things about increased, accidents or injuries. I'm a klutz. I am Butterfingers, I dropped this, I, fell. You might hear that more often. We typically expect that in teens, because when you think of a teenager, you think of, an impulsive, erratic person sometimes. And, the surprise here is the data shows us that there are actually higher rates of accidents and injuries in these older adults. You might hear them talk about higher rates of divorce and mood disorders. Like if you're treating couples, you might hear some ADHD qualities in those conversations in couples therapy. So when they're in the clinic, they may be talking about things that happen in childhood, things that happen in adolescence, and notice that they are still persistent as they progress through their lifespan. Those symptoms might fluctuate in intensity. They might be more troublesome at some points in their lives and less troublesome at others, but they are still present. And the last thing I want to point out is that it's really important to, for all clients, honestly, is to make sure that you are considering um, whether there are any underlying medical reasons for these ADHD characteristics, whether it's a thyroid condition or long COVID or age-related cognitive decline. Again, that's another reason why it's important to have like a multidisciplinary approach and having good partners in other areas to support and rule out diagnoses. So let's dig a little bit deeper in our understanding specifically of these clients that might be in your office. One of the main reasons adults seek treatment is to address their trauma history. And one of my mentors called trauma to be the biggest masquerader of other medical or psychiatric conditions. And I was really intrigued by that statement. And when I specialized in ADHD and autism, I realized that, I couldn't ignore the trauma history. Not that I wanted to, but it became very present in the office, in the clinic, in session. And that's why I wanted to make sure I included this slide. When you look at some of, and certainly this is not an exhaustive list, but it is an important shortcut list of some of the most common reasons why a client might seek support or some of the most commonly reported experiences that they have. And look at the overlap between these two categories. What the underlying reason is and what it looks like on the surface in their behaviors, you'll see difficulty concentrating, trouble with sleep, some restlessness, some disorganization. And it is really important for us as clinicians to be able to make the distinction of the origin of these needs and also meet the client where they are and treat the characteristics and the symptoms regardless of their source. So we need to do both. We need to understand where the origins are, where things are coming from, to have a really good case conceptualization. And at the same time, sometimes clients are like, I don't care where this came from. I just need to feel better. And we need to meet them there as well. So, here specifically, I want to talk about people who were assigned female at birth. So, specifically, girls and women at birth. This is a really important slide for many reasons. I want to make sure that you know that what ADHD looks like in women can be very different. For a while in the field, we talked about, oh, all the girls and women have ADHD inattentive type. They are all the daydreamers, the shy ones, the spacey ones, terms like that. And I absolutely don't think that's fair. And the research does support that women can have any of the three presentations of ADHD. They are not limited to only one subtype. So what's interesting is that on average, women receive the ADHD diagnosis much later than their male counterparts. So there's a lag in the amount of time that they have to experience benefit. And the opposite is also true. There's a longer period of distress that needs to be addressed that, sometimes is hidden. And why does this happen? They are more likely to mask better. They might be more likely to be under the radar and not, be the squeaky wheel, in a classroom setting, and might go unnoticed in that sense. But here's where the problem comes in. With that delay, they end up having a higher likelihood of, again, those comorbid diagnoses, with depression and anxiety as being the primary ones. And again, going back to that term, lost generation, these clients, girls and women, often get missed because their presentation is atypical. They are not the impulsive, fidgety, restless little boy, right? So they might come across having more social dysfunction before it affects their academics. They might get all the way to college before they demonstrate any academic distress. They might get diagnosed with a mood disorder first, like anxiety or depression, before they also get an ADHD diagnosis. And finally, one of the other reasons why a client might go in for care would be related to their eating or risk-taking behaviors that might be, the origin of which might be ADHD, but when you walk into a clinic and you talk about restricted eating and things like that, some other diagnostic criteria come up and you might get diagnosed with an eating disorder instead, and the ADHD diagnosis might get missed or ignored. Because of all of these risk factors, I think it's really important to take a minute to talk about masking. We all mask. It is a common human behavior. We do it in specific situations to help us get through it. But what I'm talking about is a higher intensity, a more chronic use of masking in the clients, but also, and here's the part we don't talk about very much at all, you might see some masking or cloaking of ADHD characteristics that are done by other people in their lives. So in the clients, sometimes we see a lot of lack of insight, or coming across as guarded, not sharing that much in session. You might see some active camouflaging, how, a client might emphasize what a good person they are, some kind of reinforcing, how well they kind of fly under the radar, how good they are at hiding their difficulties, but they're also hiding their light, and that's a problem, right? So sometimes masking can look like avoidance or lack of interest, like, oh, I didn't want to go to this event anyway. I'm a lazy girl. I don't want to try too hard, and kind of reframe in an unhealthy way some of their behaviors. And another example is buffering. So sometimes people adopt some distancing behaviors that make them look like they're coming across as arrogant or condescending, and it's a way to push people away, and it's a method towards masking. And finally, one more common way of masking is to use substances, alcohol, demonstrate some hypersexual behaviors in a way that, if I do this, then it keeps people away, or it attracts a certain type of person and I can handle that. And it sort of narrows the field of their experience, their social experience. But here's a different kind of angle at this. Sometimes the masking of a diagnosis is done by other people in their lives. And what do I mean by that? So remember that mom I was talking about who brought her son in for an evaluation? You might hear parents and caregivers talk about how much they have to be involved for their clients, and taking care of backpacks and remembering like all of the rules and expectations and carrying the load really for their child or adolescent's daily functioning. You know, um, we get phrases like, he wouldn't remember anything if I didn't do it for him. A lot of times, parents or caregivers will help the child or adolescent avoid certain experiences that might lead to some activation of these characteristics. For example, they might not have a lot of time-based activities or time-sensitive activities. They might reduce the number of extracurriculars that a client is in. They might do the opposite too. They might overbook and overfill someone's schedule just so that they are really structured out and like it's a really important activity. We need to structure the Saturdays. We can't have downtime. We hear phrases like that in the clinic as well. And finally, a lot of times we notice clients getting, as adults, getting assigned to specific teams or given extra support or being given some options that match their needs, or they might choose it themselves. So I have seen many clients opt to stay in the office versus working from home because it is more structured for them. And these are all examples of ways that we can mask for ourselves and also the way that systems and other people mask for us as well. So when do adults typically seek help? In a word, transitions. Anytime there's a big event or a big change or a phase or stage change, that's when you start to see the gaps. So for children, that's also true. When they're transitioning from, say, elementary school to middle to high school to college, you'll see things like that. There's a big drop off in college when it comes to like leaving home and having a big increase in the need of executive functioning skills, but we see it in other areas too. We see it in adults when there are hormonal changes in women as early as age 30, 35. There might be a change of demand or based on their life stage, they're getting married, and all of the planning that goes with that. They might be having their first child. Any big loss or crisis period is another important one. You might see a client reach out when they have the option to reach out. They have access based on employment to an EAP or better health insurance, and they're finally, I've heard this many times, where like, finally I can do something about this because I can schedule my own appointments and pay for it and see the doctors that I want to see. So while I'm really glad to see any client at any age come into the office and talk about these things, there are a lot of risks and impact of later and later diagnoses. And that's one of the reasons why I wanted to focus on this topic for this particular presentation, because there's a finite number of clients that I can see in my office, but if we can spread the word together and have our eyes open for others who might need a little additional and specialized support, we can reduce the risk and reduce that negative impact of a late diagnosis. So a lot of times when they come in as adults, you'll see a much higher severity of anxiety, depression, a history of self-harm, a history of eating disorders or restricted eating in general. They just come across as a higher acuity case right off the bat. So they suggest a lot of complexity. It might not seem like a straightforward ADHD, or I'm sorry, anxiety case. As you start talking to the client, you realize like there just seems to be more going on. And that, I would encourage you to question whether is it ADHD, is there a trauma history, and do your due diligence, of course. One of the other things that you'll notice is that you'll see more impact socially and how they cope with it. If you ask questions about social relationships, you'll hear some of these things like, "I'm a loner. I don't do friends. I don't know how to do that." Or, "I have friends every once in a while. It's situational, but once I leave that situation, I'm not really in touch with them anymore." Or they might cope with social difficulty by joining some preset groups that come with their own risks, like gangs, or um, coming across as highly promiscuous and like being quote unquote the bad girl, in a way that kind of gets some social interaction, but in a very, very limited, restricted way. And with that in mind, one of the other things to consider is just to look for a pattern of, sexual behaviors. So are they sexually active at an earlier age? Is there a history of infidelity given or received? Both are important. Are there any risky behaviors, physically, like forgetting the use of contraception or choosing not to? Asking them questions about how thoughtful and planned versus impulsive are their sexual choices. And then, of course, making a good referral if you feel like the client would benefit from some medical support to address any of the physical impact of these behaviors. So, this is the part I wanted to talk about: assessment and evaluation processes. Some of you may not be doing evaluations per se, but you see a client and you send them for an evaluation, or they come in with a history of one. And I think it's really important to have that background knowledge that will make it more thorough for you, in your understanding of the client, and also feel like a really good partner with their care team. So here are some standardized clinical assessments that I use in my practice. Lot of acronyms. So the first one is a direct measure of executive functioning skills. We also look at memory and learning in the second measure. We look at a rating scale for executive functioning, ADHD symptoms. The last one is a personality inventory. And I think in general, I'm not going, the purpose of this presentation is to not go into each of these measures in detail. However, I do want to make sure that you have at least a working knowledge of these terms and, what each one measures. And I've linked more information on that in the resource section. There are a lot of informal measures that we can use, whether it's a client that's come into my office for an evaluation, or they're seeing you for therapy and want to talk about it, and they ask you, like, "Do you think I have ADHD? Like, what else is going on here?" Or you might be wondering the same. And these are some important points to kind of include in a diagnostic interview and when you're taking their history. I would ask about the presence or absence of various criteria or symptoms, but I also ask about how that changes over their lifetime. So if you're meeting a 20-something or a 30-something, ask, and they're talking about being impulsive or being forgetful, ask them if that behavior or that quality was present when they were younger. What do they remember? Or sometimes I ask, like, what did your parents tell you about, like, parent teacher conferences? What did the teacher say about you on report cards? What were those messages that you got even earlier in your life? I would ask about their tolerance of risk and how much they act on that. How do they feel safe in their relationships, or do they ignore risky situations and move forward anyway, and ignore the risk and move forward anyway? Do they have some coping strategies, and how good are they? Are they functional or dysfunctional? Like I said in a previous slide, they might have a coping strategy that really works for them, but the cost of that is that they come across as condescending or arrogant, or they push people away, and it keeps them safe from experiencing that social anxiousness. So when you're asking questions, like if I was asking a young child or their parent or teacher, I would ask, like, do they talk out of turn, or they, blurt out the answer in class? And then you want to modify your language to pull for the best information. So I would ask questions like, so tell me about meetings at work. Sometimes we have formal meetings with agendas and plans, and sometimes it's just sort of a casual chit chat, drop in. What happens in those two settings? How do you feel? Are you stressed in one and more comfortable in another? Have you ever gotten feedback that you're talking too much in a meeting or taking up too much, airtime? Things like that. And, for women specifically, I would ask them to start tracking their ADHD symptoms and whether it's anything exacerbated around their menstrual cycle. There are a lot of good apps that help with that. And then ask, in addition, if they choose to pursue higher ed, whether it's community college, grad school, ask them about their academic experience and also when things may have shifted. For example, recently I spoke to someone who got an MBA, and that's when she felt like she met her match. She's like, I could not take the juggle anymore. I was working full time, getting the MBA part time. I have an 18-month at home. So there were layers that really kind of exacerbated the difficulties that she was experiencing. And then I would connect that to, were there other times in your life when you had similar feelings and it felt strained or stressful? Another one that I hear a lot is asking, whether clients have ever been described as street smart, but not book smart. So that's a phrase that I've heard often. And what to me that means that they have a savvy about them. They have some social awareness. They know how to get by, but they have difficulty demonstrating their knowledge in a traditional way, taking tests, turning in assignments, being on time, remembering due dates and work assignments or academic ones. But when you talk to someone, they come across as really, together and intelligent, if you will. So the last little bit I'll say is it's really interesting to compare their verbal responses and their written ones in an intake form or an inquiry sheet, or, some questionnaires you might have them fill out, and compare that to how they come across verbally. A lot of times I will see some tangential language in a verbal encounter with a client, and I find myself having to really keep them on track with the topic. But when they take a minute to write things down or have bullet points, then it's a lot more clear and the conversation goes better. You might see more tangential writing, just like they don't know how to edit. They give you the whole story, but then in a structured verbal conversation, they're able to get to the point better. So I just want you to compare and contrast those two types of communication. So here are a few more informal assessments. I want you to get some collateral interviews if you can. If it's appropriate, to ask a spouse or partner or adult child or sibling, a peer, a friend, things like that. If you're able to ask, it's not required to do that for an adult evaluation. But if you can, and the client is willing to give you consent to do that, I would ask, for the opportunity to talk to another person in their lives. And the thing to watch out for is when you're getting data from that source, be careful of the masking and camouflaging behavior. That can come across as bias sometimes. So when, like, let's say I'm talking to the parent of an adult child, I would ask them to kind of compare and contrast their kids if they have more than one. And that's when I can hear some bias, like, oh, this child, this is the one I have to help a lot. This is the one who, I need to support more. Sweet kid, but I've always had to do a little extra for this one, versus my other kid who seems to be, really independent and does their own thing. Some other behaviors that are common that I would ask about is, the why behind a behavior. So are they oppositional? Do they come across as oppositional even if they don't mean to? Are they chronically late to meetings and to showing up for work on time? Is that a big deal? Are they late for their shifts? And how does the person perceive that? Do they see it as a disregard for the rules? Do they see it as um, carelessness, or do they notice like good intentions but still not able to show up on time for whatever they need to do? So I would ask for the behavior and some examples of that, and also assess that person's possible bias or masking. So when you're interviewing clients or their peers or colleagues or family members. Um, these are some questions that I have found to be helpful in digging a little deeper on, the internal process, like what's happening in these situations. So, for example, what do you do when you're upset? It kind of brings out some of the internalized thought patterns and where they assign cause. I think that's a really important one. I would ask questions about their social experience, especially keeping in mind that now you can diagnose autism and ADHD together. I would always ask about friends and social experiences. How do you make friends? Do you want to make friends? How do you maintain friends? How do you keep going in a relationship? How do you know you've gone to a deeper level in a relationship? Or do you ever have that experience? What happens when you leave a work experience? Do you hold on to those relationships, or is it like out of sight, out of mind? What happens when you leave a certain area, like a college dorm or again, a work experience that, it takes some effort then, right, to kind of maintain some relationships, or do they cut their losses and leave? I would ask some questions in that area. I would also want to know what a group social experience is like for them. How much are they managing and masking and coping to get through a social experience in a group or even enjoy it? And I would ask questions about what are some things they actively avoid doing or going to, a certain length movie, certain social experiences with family, loud, highly stimulating environments. Those are a few that come to mind. I would ask them what they tend to avoid. And of course, I would ask how they would describe themselves and how others describe them. So some of the words and language we use to refer to ourselves are really revealing, and can give us some insight into what either the messages the client has received from other people or the messages that they're giving, themselves. So this next section, I'd like to talk specifically about care and treatment. And I want to consider care in the clinical setting and also resources to offer outside of the clinic or office setting, and how you might be a good member of a multidisciplinary team. So one of the big cautions here is that untreated ADHD can lead to a lot of significant risk and impact. A lot of times, untreated ADHD leads, or unidentified even ADHD leads to a lot of poor coping methods, which can lead to addiction, self-medicating with substances or alcohol, food. There's a lot of undiagnosed psychiatric disorders. Sometimes people their first experience coming into care would be related to a mood disorder, but sometimes the first reason they'll come in is um, some sort of life stressor, like I got let go from my job or, something like that. And then it's on us, of course, to kind of look and see, is there something underlying that keeps happening that, is having this client experience like the repeated rejection or difficulty. I would take a look at, learning history to see if there is maybe an undiagnosed learning disorder that went along with the ADHD. Clients who don't get an accurate or timely diagnosis of ADHD or care are more likely to be involved in the legal system, have negative experiences with educational systems, more likely to drop out or discontinue pursuit of higher ed. And a lot of times I've seen clients who seem so capable and so able and so intelligent, but they'll underemploy themselves and stay in the safe lane and not challenge because they know that there are some qualities that they have or some limitations that they experience that if they are ambitious and they try to get a job that really meets their abilities, something else will trip them up. And it will be an overall like poor performance review for them. And again, one of the most tragic things, of course, is that untreated ADHD can lead to a lot of emotional distress and a lot of feelings of hopelessness, which can lead to increased suicidal ideation and attempts. So, with all of that in mind, you can see how the care and treatment, and honestly, just having the awareness as a clinician that something else might be going on, it's a lot more present than we ever realized. So, especially in adults and women. So, some of the big areas that need attention for care and for treatment are, for example, working memory. So that's something that, affects us every single day. You know, what am I storing in my short-term memory? What am I holding in my working memory? And how can I use it? And if there is any sort of deficit that affects our working memory skills, then it shows up in our behaviors. So we want to lighten the load as much as possible. Multitasking is hugely overrated, and sometimes single tasking is the way to go. Having alerts and having on your phone or calendar, having very strict time schedules sometimes help for doing some of these things, having maybe even like going to a grocery store with a small list versus a long one might be a way to manage those working memory limitations. Another thing that I think it's important to mention is that the brain with ADHD has a big difficulty understanding the sweep of time. How does time pass, and what does that feel like experientially? So, telling a child, or honestly even an adult, like, we have to leave in 5 minutes is honestly meaningless. It'll seem like it's falling on deaf ears, but actually what's happening is that sweep of the 5 minutes is not being processed in a way that's usable. So the sender of that message can easily get frustrated. Well, I told you we're leaving in 5 minutes, but when it lands into an ADHD brain, it truly becomes meaningless. So 5 minutes, what does that even mean? What am I supposed to do with that information? So practicing that and helping the client translate when you hear phrases like this, because we can't go around and change everyone's methods of communication. You are going to hear, we're leaving in 5 minutes. The show starts in 20 minutes. We've got to go. Or we only have 5 minutes left on, the exam period, things like that. We can't change everyone's way of communicating, but we can help the client like process that information a little bit differently. Saying things like, so when you hear this phrase, this is how you should change your behavior. Your body should move faster. You might need to cut some step in your process to get out the door on time or close to time. So to help them understand that communication gap is a really important one. Which leads me to say, when it comes to tasks, there are so many that are chained together that it might be important to learn how to edit. And that involves some starting, some stopping, switching. Let's say someone's coming over and my house is a mess. And they're going to come in half an hour. And there's no way that I can do a deep clean of my house in half an hour. I've let things go too much. So I need to take a quick decision of like, what are the key areas I need to edit from whole house to specific areas. I don't think my guests are going to go upstairs into my bedrooms. They're probably going to be in the family room and the kitchen. So I will target those areas. I need to start and stop in a timely way that helps me get to the end goal. And I might not be able, I need to also ignore the fact that the rest of the house is messy and focus on this specific area that helps me get to the end goal of having a clean house or clean areas of my house when a friend is coming over. So we also need to make the distinction between what are good areas to work on quick decision making and what are areas where you need to have like a more involved, more complex problem solving strategy. So one phrase that I like to use is pick is quick. So if we're at a restaurant together and then my friend has ADHD, we can't be waiting indefinitely while they go through a 20-page menu trying to decide what to eat for dinner. This has come up more often than you'd realize in session. So it's not an uncommon experience. So it's one meal. It is one moment. Pick something. Pick something you like. Pick something tried and true. And that's your rule. I will always order a burger or soup or something like that. Other situations that happen less frequently or are more expensive or more impactful in your life are not quick and impulsive decisions. For example, buying a car, buying a house, picking a college, picking a partner, choosing between different job opportunities. Those are not things that we do every day. So those should take longer and involve more problem-solving strategies like decision-making trees, pro-con lists, talking through different scenarios, making a list of what-ifs. Those need some more involved discussions versus deciding what's for dinner. And probably the number one thing I hear in session is like, I didn't feel motivated to do blank. And well, if you're waiting for motivation, it's going to be a long wait because it's not coming. So, and more often than not, waiting for motivation doesn't lead to getting the job done. It leads to procrastination. So the reward is in the waiting. So the reward is not in completing the task. So what you want to do is reward the starting of a task versus rewarding yourself for waiting for something. So what do I mean by that? For example, if I have a report to write, I do evaluations, and writing the evaluation report is time-consuming. These reports are typically 15 to 30 pages long. There's a lot of different data to pull together. It is an important document. It might stay with the client for a long time. They might use it for specific reasons like advocating for supports at work or in college. So it's an important document. And for me to get started, I need to reward the starting of writing this report. Because if I I'm only waiting for the reward of like, oh, I'll feel really good when the report's done and in the client's hand. That doesn't help me get started. So the way to get started would be not, well, when I feel like writing, I'll get started. Instead, what I would want to do is start with an easy part of the report, number one. Like make it easy to get started by maybe just doing some formatting or doing some of the easy copy paste of some tables and things like that, and put off some of the harder parts of the evaluation report when I am more like in the zone, when I've already started working. So I'm rewarding starting by, oh, the first thing I do is pretty easy. So let me make it easy on myself. Let's get going. It's just one example. Another one is, in the care and treatment of clients with ADHD, it's really important to keep considering their social experiences and some of the interpersonal difficulties that they may have. You know, it is something that's been ignored for a long time, the social impact of having ADHD. And instead of using terms that are more personality based, like, oh, you're lazy, or you're not interested, or you're callous, or cold, or arrogant, or things like that, we want to figure out a way for the client to get the type of social experiences that they really want to have. And in order to do that, we need to help them build specific skills like impulse control, emotional regulation, self-regulation, and assertiveness in their words and actions. So focusing on these specific skill building strategies will help them individually, but also in social situations. Now we're at my most favorite part of the presentation. I can't wait to walk you through some composite case examples. So here are three clients. We'll start with Tim, who is an adult. He's brilliant. He has multiple degrees in pretty complex topics, actuarial science and physics, and pretty abstract and difficult content. But he's unemployed. He lives alone. He has some friends, a few, two or three. He's not in touch with anyone from his childhood. The friends that he describes are more recent arrivals into his life. He has trouble structuring his day on a daily basis. So when he has appointments with me, let's say it's a 10 o'clock appointment, he has told me that he's not able to do anything else that morning until we have the appointment, because he's holding in his working memory the fact that we have an appointment at 10 o'clock. I kid you not. This is actual content that I've heard in multiple sessions from different people. So they ask for morning appointments. That's a strategy. They ask for morning appointments so that they don't lose a whole day waiting. But they truly feel like they're waiting. They have good intentions. They don't want to forget. They don't want to miss the appointment. But they feel like they can't do anything else, that their brain is fully consumed with this waiting, this job of waiting. Another example that Tim has given me is that on his way to work or to another activity, he cannot go, for example, to the grocery store. He might have a list of items that he wants to get from the grocery store, but the amount of time that he needs to allocate for going to the store feels ambiguous to him, and he's not able to estimate how long that takes. So again, going back to that sweep of time, he doesn't know how long a list of 5 things will take, or 10 things. So he would rather do it on the way back from something where there's no other deadline. It's more of an open-ended time frame, so that he can not have that additional time pressure. And while that coping strategy could work many times, sometimes he needs to do it on the way out of his way to do it in a different order. So we've talked about dividing the list into having like a have to get versus nice to get or might get, and writing it down on a piece of paper in two different columns so he can go enter the store, pick out the items that he has to get that day, and then check the clock. In fact, we've written down check the clock, and if it is at this time or later, he needs to wrap it up, go to checkout, go on to his next thing. If there's cushion, if he has 15 minutes, he can pick two things from the other side of the list. And we're very concrete about it initially, so he gets that practice. And then he's able to feel more confident in his ability to understand the sweep of time and how to apply that in his real life experience at the store. So now let's switch to Catherine. She's a younger adult. She is in her 20s. She has completed a college degree. She is employed at a university. And she's entered the world of dating. She's finished life on a college campus. She lives in a mid-sized city. She has some contacts from college and from like alumni and also friends and colleagues from work. And she's decided that she wants to attempt dating. But at the same time, she's developing these relationships at work and trying to be a good friend, trying to see people outside of work, and she's finding that her social battery is draining really fast. That if she overcommits to like seeing her family, who are a few hours away by drive, and then sees friends for a movie or dinner or something like that, then she has no energy left. So she's finding that, over a period of 4 weekends in a month, she's really limited on the number of times she would even attempt to open the dating app and make this extra goal. And she's starting to sell herself short and say, maybe I don't want a relationship right now. Maybe it is not the right time. And that's an example of that distancing behavior where she starts to undercut the goals that she set for herself because it just feels too difficult. The other thing that's at play for Catherine is rejection sensitivity. So that's coming out in our conversations big time. I'm noticing that she's hyper focused on getting attention and approval, compliments, and from based on her work in the office, but also, even the smallest, slightest difficulty, she really takes it very hard. So she was running late for an appointment once. She messaged me. She was only 3 minutes late, and she just spent the next 5-6 minutes apologizing for those minutes. So the time was ticking along, and I needed to intervene here. But it gave me some insight about how much pressure she put on herself and how hard she felt, how hard it felt to understand, like, okay, there's a range of the word on time. 2 or 3 minutes late does not mean you need to come down on yourself so hard. But she, had a very rigid view of that, and then that led to some very heightened emotions and feeling very sensitive about that perceived rejection. So, and my last example for today is Joy. She's an older adult. She's in her early 40s. She has 2 children, late elementary, early middle school age. She is the manager of her household. Her husband works full time. She has a part-time job and handles some, if not all, of the home tasks. Her biggest difficulty that we talked about recently was managing meal planning and meal prep for her family. So she was having trouble going between a decision and a pick, trying to decide whether, how to plan, how to accommodate for different allergies and food preferences. All of that decision making felt overwhelming to her. So we came up with a plan to have a step-by-step strategy for decision making. So there were some non-negotiables. Like, we wouldn't pick a recipe that had nuts in it or gluten in it, for example. So we started with the most complex need, if somebody's a vegetarian or something like that. And then we adapted the rest of the planning to people who are more flexible in their eating choices in the family. So we went from specific to general in that case. And it had a roadmap for her to make future decisions each month and each week on how to plan for this. And it really felt like a big release for her to have a roadmap and a plan versus facing, a blank sheet of paper for her grocery and menu planning list each week. So that was definitely a win for Joy. Here's a list of resources that I wanted to make sure you had. There's certainly more, but this is a great place to start. I think some of them would be great to share with your clients after you've previewed them. Some of them are really good background information for you to get some insights on the life experience of various adults and women who have shared their experiences. Um, I really enjoyed sharing this content with you, and I hope that you find it useful as well. These are some options that you can use to stay connected with me. I love talking about this topic, and I'm more than happy to share um, future resources with you. Let's stay connected. Feel free to follow me on Facebook or Instagram or message me through my website. And I hope that you find a way to support your clients just like I have. Take care.